Thank you, Sujit. It's always a pleasure to be here at Hyderabad with Yashoda, and thank you to the organizers for inviting me. And of course, a lot of very familiar faces in the audience and a lot of young faces. My talk is going to be mainly pitched at the postgraduates. There's no point in talking to the experts here. They all know more than I do. I bring you greetings from Narayana Health, the place where I work. And that's my conflict of interest statement. So my plan, why should one know about CTD ILDs? How do CTDs affect the lungs? And how does this pathophysiological process present? How it presents histopathologically, clinically, and radiologically. Knowing all this, how do we recognize in our patients the presence of a CTD ILD? And having known it, how does one manage it? I'm not going to be talking about the pharmacological therapies. Dr. Padmanabh Shenoy is far more experienced at that and going to be talking about that. So why should one know about CTD ILDs? Mainly because they are common and because the prognosis and treatment are different from the other ILDs. So you look at the international data on CTD ILDs. So this is this good paper by Martinez et al., which showed a 20% prevalence of CTD ILDs among all the ILDs in an international registry. What is our experience in India? You've already heard about the ILD India registry, which picked up, that's the column on the extreme right, HP prevalence of 47%, which clearly put all the other ILDs much lower down. So they reported a 13.9 to 14% prevalence. The data from PGI says it's about 12.7%. And PGI, the problem is they have a lot of sarcoidosis because they are an expert center on sarcoidosis, center of excellence. So you can see that their prevalence of sarcoid was 42%. Ours was about 18%. So we looked at more than 400 of our patients. We discussed at the MDT. And we got about 18%, which seems fairly close to the international data, while our HP was only about 11%. So clearly there's a difference between one place and the other in the prevalence of these conditions. But overall, you can say that CTD ILD is common, somewhere between 10 and 20% worldwide. And it's important to know this because even if you have the same UIP pattern, and it's not IPF, it's CTD, then the survival is much better when you have a UIP pattern with CTD than with ILD. And while the etiology matters, the pattern also matters. So you see on the left, the graph shows you that patients with an idiopathic UIP pattern tend to have a far worse outcome than those with a CTD ILD pattern. You can make out this is an old study, it was still called collagen vascular disease. And on the right side, you have patients with two different patterns and two different etiologies. So you have the solid circles, which is the UIP pattern, whether it is a UIP IPF or UIP which is CTD related. And you find the CTD related UIPs do much better, as you've already heard previously. But when you look at an idiopathic pattern of NSIP, they do far worse than patients who have a CTD related NSIP pattern. Essentially, what this is telling you is pattern matters, etiology matters. We need to look at both when we are looking at a patient with an interstitial lung disease. And there was this small but very well-conducted study from Korea which looked at how NSIP responds to steroids. And you can see that these people looked at biopsy-proven NSIP, small number 35, found that over 86% were steroid responders and only 14% were non-responders. And among the steroid responders, you actually got good improvements, while a few at least remained stable. While in the steroid non-responders, they tended to progress, and more than 60% were dead at the end of 5 years. Whereas more than 80% of them had no relapses. Of the 80% who improved, most had no relapses, and all of them were alive at the end of 5 years. So that's why you must pick up this group, the NSIP group, especially the ones with CTD ILD, remembering that NSIP is the commonest presentation of a CTD. Very briefly, what are connective tissue disorders? We used to call them collagen vascular disorders, quite rightly, because the abnormalities are in the collagen, and a lot of this is centered around the blood vessels. So you have impact on the blood vessels, but also collagen-containing tissues everywhere. They start out probably with the genetic background. There's a epigenetic overlay, and then you have an environmental trigger which sets off the whole overt connective tissue disorder. It can be either B cell driven or T cell driven, but ultimately you get chronic inflammation, and this inflammation can involve all systems because the targets of these autoantibodies which drive this are present virtually in every system. And you all know the specific entities that we as pulmonologists commonly see. There are certain susceptibility genes specific for each kind of CTD. I'm not going to go into these details, and I'll come back to one of these at least in the future. Antibodies can be both specific and non-specific. They're predominantly directed against nuclear antigens, but there are some conditions where you get cytoplasmic antigens also. And the presentation of the impact of these autoantibodies can vary from a very limited, non-progressive kind of lung involvement to a very fulminant, life-threatening involvement. And it affects all compartments: airways, alveoli, interstitium, the blood vessels, the pleura. So the targets can be anywhere. We're going to be focusing only on the interstitial compartment. The lesions can be diffuse or focal. And when you look at the clinical features of the ILD can precede those of the connective tissue disorder by a couple of years or even more. Or the ILD can appear in a person who already has an established CTD, no ILD features initially, later developing the ILD features. And the presentation could be either an acute or a chronic feature, and it can be a mixture of lung and pleural manifestations. And that's sometimes useful. If you have interstitial features along with pleural manifestation, it kind of points you towards a strong possibility of a interstitial lung disease associated with CTD. But to add to the confusion, many of these patients with CTD actually are on immunosuppressive medication. They're very susceptible to infections. And therefore, when you have to interpret their clinical features, their radiological features, their histopathological features, you've got to keep in mind that some of these may be due to the infection or to the drugs that the patient is taking. When you look at the lungs specifically, we know that the lungs have a large surface area and they're bombarded with stuff both from the outside and the inside, the airway and the vascular approaches. Now we know, and this is one of the first things we study both in physiology and later when we are in pulmonology, is the upper lobes have a relatively poorer blood supply and the lower lobes have a relatively better blood supply. So when you have an inhaled particle, its distribution depends on the size of the particle, and it may end up finally in the lumen of the airway, in the alveolus, or in the interstitium. And depending on where these land up, you will have different kinds of macrophages, whether they are alveolar macrophages, luminal macrophages, or interstitial macrophages, which are tasked with handling these. Most of the particles from the lower and middle lobes are cleared successfully because of good blood supply and good lymphatic drainage. But because of poorer blood supply and lymphatic drainage in the upper lobes, these tend not to get cleared very quickly. And they can trigger off a systemic inflammatory response, an immune response, inflammation, and then this progresses later to either fibrosis or granuloma formation. And therefore, depending on the type of immune pathway, either a Th2 or a Th1 pathway, you'll either get well-formed compact granulomas or looser granulomas. In the lower lobes, where you get more circulation, substances carried through the circulation seem to cause greater damage. So toxins carried from the vascular system cause predominantly lower lobe disease. And as you go to the periphery of the lung, circulation is slower, so the transit time taking longer, there is greater damage occurring in the periphery of the lungs. And therefore, you get more damage in vascular diseases more towards the periphery. I'm not going to go into this because we basically discuss this, but the UIP pattern, basically, you get smaller particles distributed, more stretch forces, and therefore more damage to the periphery, which can lead to a UIP pattern. So, essentially, the severity of the injury determines the severity of the fibrosis, while the cause of the injury, how it reaches the lung, determines the distribution of the fibrosis. So we are looking at inhalational injuries, vascular injuries, both determining where the disease is seen predominantly, though it's distributed throughout the lung. You have to go by the etiology of what is causing the disease, as well as you can make out the duration and the severity of the injury by looking at the extent of the pathological or radiological involvement. Finally, all this injury leads to inflammation, and the body responds to this inflammation by trying to repair it. That's again one of the first lessons we learned in general pathology. And you have two kinds of repair. That can be a complete repair, which is what we're aiming for. Unfortunately, sometimes it's only a partial repair, and sometimes it's an ongoing attempt to repair which causes greater harm. Then there are two ways in which to do this. One is the resolution, which leads to a complete restoration of the architecture, and the other is organization, where you end up with fibrosis and distortion of the architecture, because organization leads to formation of fibrous tissue. So, though the insults to the lung parenchyma are virtually infinite, the response patterns that we see are finite, and therefore it's important when we look at the CT scan to look at the predominant pattern of that particular disease before you can initiate the diagnosis and treatment. So this is kind of summary. I'm not going to go into it for lack of time, but always remember that you can have an airway end and a vascular end. The responses of the body to the whatever is causing the injury occur in various compartments and ends up with fibrosis ultimately. And where the fibrosis is will tell you where the problem started. And this is how you will get healing after inflammation, where initially you see an inflammatory pattern, predominantly ground glassing, and the fibrotic ILD pattern, which is the end result. As has already been emphasized, this is often too late to do anything. And let me skip this also, except to say that you can have both innate immunity and adaptive immunity kicking in. And we think that it's predominantly innate immunity responses which lead to predominant fibrosis, typically seen with the IPF pattern, while your adaptive immunity comes in when you're dealing with CTDs. But I particularly like this slide, and I always show it when I'm talking about interstitial lung disease, because it came as quite a news to me. On the top, you have the etiologies. But remember that every etiology can result in these patterns of disease that we are seeing. So for example, autoimmune disease, when it produces an organizing pneumonia, can also lead to an NSIP pattern, which can be either cellular or fibrotic, or it can even lead to a UIP pattern, as occurs very often in rheumatoid arthritis. And if you look at this end of it, where the organizing pneumonia is, you typically get mostly inflammation, while in the UIP pattern, and for example IPF, you get predominantly fibrosis that may respond to antifibrotics, while the inflammatory pattern responds very well to anti-inflammatories, and we need to catch it before it moves towards the fibrotic end of the spectrum. And this is equally true of your CTD ILDs. You get interstitial lung disease in approximately 40% of patients who have a connective tissue disorder, and as I emphasized earlier, these have a better prognosis. The risk factors may depend on various things. In rheumatoid arthritis, for example, age, smoking, the male gender, and the severity of the rheumatoid arthritis can tell you if you're likely to develop an interstitial lung disease. But interestingly, the MUC5B gene, which is something that's also found in IPF, also codes for the UIP pattern that you see in patients with rheumatoid arthritis. In systemic sclerosis, the SCL70 gene and the nuclear pattern ANA carry a greater risk for ILD as compared to the centromere antibody pattern, which seems to give you a higher risk for pulmonary artery hypertension presentations. And again, with the idiopathic inflammatory myopathies, you get a different set of HLA antigens which seem to code for it. So knowing all this background, when should we start suspecting that a person with an ILD may have a CTD underlying the interstitial lung disease? The problem is the diagnosis often rests outside the respiratory system that we are used to examining. The symptoms are very non-specific. They can happen virtually anywhere. You can have constitutional symptoms, fever, weight loss, fatigue, and so on. Very common symptoms with all the ILDs, irrespective of whether they have an irrespective of all the CTDs, whether they have an ILD or not. Respiratory symptoms are common to all the ILDs. Nothing changes. They have cough, they have breathlessness, they have fatigue, and this cough is typically a very dry cough with no particular distinguishing characteristics that will tell you this is an ILD related to CTD or not. But for a CTD, therefore, you must look outside like the rheumatologists do. Start with the hair, look at the face, look at the hands, look at the joints, look at the mouth, look for dry eyes, look for red eyes. Okay, so the clues lie outside the lungs and not in the lungs. So we rely on 4 areas predominantly: the clinical features, the serological tests, the histopathology, and the imaging. And if you look at the age, CTD-ILD typically occurs in the middle age. It does start in the young age, goes on to the old age with a peak around the mid-50s. Gender-wise, CTD-ILD is far more common in women than in men. Involvement of other systems will give you a clue. So if you look at a younger ILD patient, a female ILD patient, a non-smoking ILD patient, you probably should be looking even harder for a connective tissue disorder. I'd recommend people read this position statement. It came out about a year ago from the Australia-New Zealand Society. And they make this important point: the clinical features of a CTD at the time the ILD is diagnosed may be subtle, not volunteered by the patient, or even non-existent, and you've got to really try and dig it out. Serology is the first point we go to, and we can look at various ways of looking for serology, various different autoimmune tests, and I'll just call your attention to the last half of it, which said we need to balance sensitivity and specificity, reproducibility, cost and convenience. But very, very importantly, we need to know of the lab we use, what are the positive or negative values, when do we call it borderline, what are these thresholds that people are using. You need to talk to your lab before you can interpret them. And always, always, it should be in the clinical context of the patient, and always take the opinion of your rheumatologist. We've already heard he or she is such an important part of your multidisciplinary meeting. And we work very closely with our rheumatologist. There are various common antibody associations. I'm not going to go into this. We move on to imaging, and imaging does several things. It confirms whether you have an ILD. It establishes the pattern of the ILD, whether you're dealing with an organizing pneumonia, an NSIP, or a UIP pattern, or mixtures of these. It may suggest that there is a CTD as an underlying cause for the ILD. And remember that all patterns are possible with the CTD-ILD, so you need to look at these subtler clues. The most common pattern, as I mentioned already, is the NSIP pattern. UIP is less common. Organizing pneumonias are even less common. It's only in rheumatoid arthritis that the UIP pattern is commoner than the NSIP pattern. And in the idiopathic inflammatory myopathies, organizing pneumonia often overlaps with the NSIP pattern, such as in this patient, where the organizing pneumonia is very clearly seen, along with the background of an NSIP pattern. I didn't go into the HRCT because you're going to have a talk on that today later. Radiological features that favor that you have a CTD along with a UIP pattern, so it's not an IPF but more likely to be CTD, is something you've already heard, the anterior upper lobe predominance, and the probability of having a CTD underlying it is almost double that when you have the anterior upper lobe sign. The exuberant honeycombing, you've already heard, greater than 70% of the fibrotic areas are involved. Your ratio of finding, likelihood ratio is approximately 3.7 times. And the straight edge sign, again, you heard about, almost increases it by 4.25 times, the likelihood ratio of being a CTD-ILD. So look for these very, very carefully. But one of the things that we should always look for, even when it's not a UIP pattern, is the esophageal dilatation that you're seeing, which often gives you a clue to the underlying CTD. So look for these signs, please. There are various pathological patterns, and again, mirroring what you saw in the radiology, is that NSIP far outweighs the others when it comes to the pathological pattern also, except in rheumatoid arthritis, where the UIP pattern is common. So let me just take you through the last part of this, outcomes. When you have an RA-ILD, you tend to have a poor survival, a 5-year survival about 36% when it's a UIP pattern, but a good survival when it's an NSIP pattern. With the interstitial, the idiopathic, myopathic patterns, you tend to have a 60 to 80% survival, but there are some which have a very rapid progression and the person can die within a few months. And the 5-year survival when you have a systemic sclerosis with an NSIP pattern is around 85%, and probably better now that we have nintedanib with us. Let me skip the inflammatory myopathies, a complex group which you have to look for. They may not have any obvious features of myositis when they first come to you, and you've got to look for them when you look for the various different autoantibodies. These don't form part of the normal panel, so please be aware of these. Always look for pulmonary hypertension. Always look for cardiovascular involvement, which is common when you have a CTD. Look for involvement of other systems. As I mentioned earlier, these involve all areas. Look for evidence of a latent TB infection, because we are going to be putting these patients on immunosuppressive medication. Very important that you don't start them without looking for latent TB infection. Please look for muscle weakness, especially diaphragmatic weakness. Check their oxygen saturation at rest, on exercise, and at night. And I'm going to skip this last part for lack of time, but please remember that there are these conditions called IPAF, interstitial pneumonia with autoimmune features, and we look for domains, at least 2 out of 3, to explain the presence of an IPAF. It's still a research term. And it's important to pick this up because treating these people gives you very good outcomes. The other term that has recently been used is interstitial lung abnormalities, which don't even meet the criteria for a CTD or an ILD, but you pick these up incidentally when a CT is done, probably for something else, or even when you do an abdominal CT and the radiologist notices that there are some patterns or interstitial abnormalities at the base. Pick these up, investigate these patients, because they have a better prognosis if you can pick up this abnormality early and follow them up. Last couple of slides, other therapies, oxygen therapy, very important. GERD treatment, like you heard in IPF, it's very important to look for GERD treatment. As you saw, the esophagus is often dilated, and GERD is a very common problem with these patients. Pulmonary rehabilitation early when they become symptomatic, it's not an end-of-life care. Remember your vaccines. Now, as in COPD, we recommend 5 vaccines. Zoster vaccine is not yet available, but influenza, pneumococcal, COVID, and Tdap must be given. Supportive and palliative care throughout the course of illness, not only when the patient is entering end of life. And of course, lung transplant sometimes, because patients do not respond to treatments, and some of these patients need both a heart and lung transplant. So take-home messages. CTD ILDs account for 15 to 20% of all ILDs, and it's important to identify these because the prognosis is usually better than in the idiopathic counterpart. The CTD ILD may precede or follow the diagnosis of the connective tissue disorder. The clue to the diagnosis of the CTD ILD lies often outside the lung and not within the respiratory system. And again, repeated examination is important because you can pick these signs up later rather than when you first diagnose the ILD. The pattern of ILD on the HRCT gives you the clue as to the kind of insult, its severity, and the probable cause. Confirmation is by looking at the serology and the antibody patterns. Increasingly, we are recognizing IPAF, though it's still a research term, and interstitial lung abnormality should be followed up and may have very important clinical significance. And management is not only pharmacological, which is going to be the subject of the next talk. Thank you.
Sir.